There are several big issues in screening. First has to do with the screening tests themselves. And the recommendation has been for years now that ultrasound is the screening test of choice. Biomarkers were alpha-fetoprotein and DCP and alpha-fetoprotein L3 were used some time ago. They fell out of favor. Now they seem to be coming back a little bit in terms of assessing patients who might have cancer. So they're the screening tests themselves. And the second issue is how to identify who should be screened. The original AASLD guidelines were very broad. We just didn't have information in which to provide a more refined estimate. And a lot of that information has now become available, and there are a multitude of different risk scores which would help to narrow the pool of patients identified by, say, cirrhosis. And we know that patients with cirrhosis are at risk, but not everybody with cirrhosis is at risk. So how do you identify those who are and who are not, so that you don't have to screen those who are not at risk? That data is starting to come out. Hepatitis B is perhaps a better example, because we know that only about, if you don't treat them, 25% of men with hepatitis B will develop cancer. So what about the 75%? How can we avoid having to screen them? Once again, there are risk scores that are being developed and are being published and not entirely validated yet, that will allow us to hone in on those patients who are most likely to develop cancer. What's not yet established is, when you do these kinds of studies, what is the threshold? What is the threshold that you should start screening? That's the threshold of risk. And when you look at a risk score and you look at how good it is, what proportion of patients who eventually develop cancer does it identify? It's never going to be 100%. What is the threshold that we can accept? If they identify 70%, is that good enough? If they identify 80%, is that good enough? That we haven't, as a community, decided what the appropriate level should be.